Good morning, everybody, and welcome to the 10th Public Health Grand Rounds. It's unbelievable. I was just talking to a couple of people a few moments ago that 10 months ago when we started this, we could barely get people to come in because this was going to be another talks and series of whatever. And right now we're having people coming to us and wanting to get their topics on the agenda because they understand there is going to be a large number of people at CDC and even larger audience outside of CDC. So let me just say a few obligatory and a couple of other words just to remind everybody, because we get this question all the time, that this can be viewed by everybody within CDC. It's on our intranet on the directors page, but also it can be viewed by anybody who has internet access anywhere in the world. And we are getting, really proud to say, more and more viewers outside of CDC. Last time it was record-breaking chlamydia. You can draw the whatever conclusions you want. Over 14,000 people watched us live outside of CDC, and we estimate that it's another 1,000 people within CDC. So this was our record-breaking. Some of you who may have been here remember that, you know, our audiences are getting bigger and bigger, and this was like after a few months we had massive crowds. Then we wanted to move to the Jon Stewart show, and somehow that didn't quite work out. And so we're now attacking the YouTube. Now this one is not wishful thinking. I would like to introduce very quickly Shane Joyner. Shane, where are you? Where is he? Oh, he stepped outside. Oh, there he is. Come on in and wave. I really wanted people to see who he is. Shane is not the YouTube guy, but the person who directs so many aspects of these events, from media, communications, policy, everything else. And he is the one who is going to make it possible. He is working with YouTube people to have us be on there so that we can be clickable and that you can actually watch us through YouTube. And he explains to me that that's better because when you search for the Grand Rounds, you can actually be much easier to find us, and also because of the capacities of their server, it's going to be a much better reception. So I really wanted to recognize Shane for that kind of work. Also, we have been pointing out another relatively new activity that has been going on for about a year, the same way as our rounds, and that's the science clips, which are now coordinated with the events on the rounds. And so here I do want to recognize Deb Galuska for her selection of the obesity topics in this week. We are continuing with the continuing education credits. Those who are interested, please go to the web page and make sure you can get credit for being part of this. We are also continuing with submitting our editorials or commentaries to the MMWR. The first one came a couple of months ago on tobacco. We just submitted one yesterday, and it was accepted on radiological and nuclear preparedness. And I just heard from our colleagues that our next one on folic acid and fortification is going to be coming soon. So all of these are turning into publications. This is the list of topics coming up in the next few months. So please stay tuned. And since Dr. Frieden is not here today with us, but he's with us in spirit, and trust me, on email and with comments very intensively, we're going to have a few taped comments from him.
Today's Public Health Grand Rounds concerns one of the most serious epidemics facing the U.S., obesity. Obesity kills more than 100,000 Americans a year and costs about $150 billion a year to treat. It's linked to an unhealthy environment that promotes overconsumption of sugar, salt, and fat. Children in particular are at risk. Their obesity rates have tripled in a generation. As you'll see in this session, changing the food environment is critical to empowering Americans to live healthier lives. The First Lady's Let's Move campaign represents a fantastic opportunity to mobilize every sector of society to help families make healthier choices, improve nutrition in our schools, increase physical activity, and expand access to healthy and affordable food. Reversing the obesity epidemic is a leading public health challenge of our time. Key roles for CDC include better understanding the epidemic and helping state governments and local communities to implement and rigorously evaluate programs. Thank you.
And so with that, we're going to burst the bubble of our speakers. Between Tom and me, we're going to tell you everything you need to know. So the next thing that I do want to mention is that obesity has always been an important topic, obviously, not only for the people who are working on this, but just a couple of weeks ago, on my birthday, June 2nd, our current Surgeon General actually had an article, an interview in JAMA, and actually pointed out that physical activity, obesity, nutrition is one of her top priorities. And then yesterday, as I was driving home and listening to the news, I heard about President Bill Clinton's Healthiest School initiative in Georgia. And actually they were saying, and I picked it up from the web this morning, that there are 7 schools in Georgia that have been recognized in Atlanta, in Fulton, and DeKalb County for all kinds of activities they have brought to improve health and obesity and nutrition in schools. So this is really more than timely, again, that we're talking about this. Now, as we have moved over time, we have had more and more women participating in these events, and as I always say, women rule. And so here is a spectacular trio of women who will be talking and giving their presentations to you today. But however, you always have to have somebody coordinating the event. And so, you know, our coordinator of the day and the Iron Man of the day is Bill Dietz, who is the key person for obesity nutrition at CDC. So allow me just to say what we will be doing is you will be hearing, 101 on obesity. We will move to what the challenges and opportunities are. Bill will address that. We will have Judith Bell talk about big changes, policy and system changes that are needed to move things. And then, as Dr. Frieden says, we want to see how it's all done and how it all fits when it comes happening at the state level, and so Torie Rodgers is going to close with that. And so I'm inviting our first speaker, Cynthia Ogden, to come up here, and I'm going to get your slides going. Yeah.
Good morning. My name is Cynthia Ogden, and I'm with the National Center for Health Statistics. My charge today is to lay the groundwork to show who is obese, to define the term childhood obesity, and to discuss the consequences of childhood obesity. We all know that the level of childhood obesity is high in the United States. In fact, based on measured data from the National Health and Nutrition Examination Survey, we know that 12.5 million children and teens are obese, almost 17%. The rate is twice as high among adults. 34% of adults are obese, almost 73 million men and women. Our focus today is on childhood obesity, but children eventually become adults, and this is what is happening to adults in our country. American adults are on average 24 pounds heavier today than they were in 1960. Diabetes, a serious consequence of obesity, affects 23.5 million, or 10.7% of American adults. More than half of these individuals are obese. Obesity refers to excess fat tissue, but this is impractical to measure clinically or in epidemiologic studies because it is both time-consuming and expensive. Consequently, excess weight for height, which is easy to obtain, is used as a proxy for obesity. The most widely used index is body mass index, or BMI, defined as weight in kilograms divided by height in meters squared. BMI is recommended for use in adults, adolescents, and children, but it does not distinguish between body fat and muscle. Using BMI in children is more complicated than using BMI in adults. Unlike in adults, there are no set risk-based cutoffs of BMI used to define obesity. And BMI in children varies with age and sex more than it does in adulthood. Consequently, a statistical definition of obesity based on BMI for age is used. Children's BMIs are compared to a reference population of the same age and sex. In the United States, the reference population used is the BMI for age 2000 CDC growth charts, which represent the US population 4 decades ago. Children at or above the sex-specific 95th percentile are considered obese, and those between the 85th and the 95th percentiles are considered overweight. There is no agreed-upon definition of severe obesity in children. Today, I am using the 97th percentile as the cutoff for severe obesity. Children between the 5th and the 85th percentiles are considered healthy weight. To bring this discussion back to actual children, here you can see a child considered a healthy weight using the BMI for age definition. This child is considered overweight, and this child is considered obese. BMI is not a perfect measure of body fat. You see here the percent of girls with excess body fat within BMI categories. Obesity is clearly associated with body fat. The majority of girls in the obese category have high body fat. In the overweight category, however, more than half of U.S. girls do not have high body fat. Moreover, there are significant differences in body fat between race-ethnic groups at the same BMI level. African American girls are significantly less likely than non-Hispanic whites or Mexican Americans to have excess body fat in the three BMI categories. This difference is particularly striking in the overweight category. A similar picture is seen among boys. Turning to obesity trends, we can see a rapid increase in the prevalence in the 1980s and 1990s. The prevalence of obesity among children and teens tripled from approximately 5% to more than 15% in 20 years. During the last 10 years, however, the rapid increase in prevalence seen in previous decades has slowed. In fact, there were no significant trends in obesity prevalence among children and teens. Unfortunately, among boys 6 to 19 years of age, there was a significant increasing trend in severe obesity. The prevalence of severe obesity rose from 9.3 to 15.1% over the last decade. The heaviest boys are getting even heavier, and this was driven by an increase among non-Hispanic white boys. Significant disparities exist in obesity prevalence. Hispanic boys and African American girls are disproportionately affected. Older children and teens are also more likely to be obese compared to preschool-age children. Contrary to popular opinion, the relationship between socioeconomic status and obesity is not consistent across sex and race ethnic groups. Among whites, there is an inverse association. For example, a significant inverse relationship exists among non-Hispanic white boys, but not among African American or Mexican American boys. The bottom line is that obesity is a concern for our entire population, not just the poor. The levels are not different among the middle classes compared to the poor. Importantly, there are cost consequences of obesity. The costs of obesity have increased dramatically in the last 10 years. One estimate put the cost of adult obesity at $147 billion annually, over 9% of all medical costs in 2008, up from $78.5 billion in 1998. Approximately half of these costs are paid by Medicaid and Medicare. Because severity affects costs, these data suggest that obesity in childhood that persists into adulthood may contribute disproportionately to the costs of obesity. In the short run, childhood obesity can lead to psychosocial problems and cardiovascular risk factors such as metabolic syndrome, high blood pressure, high cholesterol, and abnormal glucose tolerance or diabetes. In one study, 70% of obese children and teens had at least one additional cardiovascular disease risk factor, while 30% had 2 or more risk factors. Although the prevalence of type 2 diabetes in teens is very low, a recent report estimates that type 2 diabetes represents about 15% of new cases among children and adolescents when it was virtually unheard of 3 decades ago in teens. Blacks, Hispanics, and American Indians are overrepresented in this group. Childhood obesity also has long-term consequences. Obesity in childhood tracks to adulthood. Obese children often become obese adults. And obese adults are at increased risk for many health conditions, such as diabetes, cardiovascular disease, and certain cancers. This relationship is stronger in older children. Although there is variation in study results, in one study, 87% of obese adolescents became obese adults. And 39% of these obese adolescents actually became severely obese adults. Risk factors in childhood can become diseases in adulthood. In sum, there is a childhood obesity crisis in the United States. Although BMI is an imperfect measure of body fat, the prevalence has tripled since 1980, but the rapid increase seen in the 1980s and 1990s has slowed. The only significant increase in prevalence seen during the last decade was the prevalence of severe obesity in boys 6 to 19 years of age. Hispanic boys and African American girls are among those with the highest rates. Childhood obesity has serious consequences, including significant financial burden, increases in cardiovascular risk factors and the precursors to diabetes, and over the long term, childhood obesity often tracks to adulthood. Thank you. Our next presenter is my colleague, Dr. Bill Dietz.
Thank you, Cynthia. Good morning. My name is Bill Dietz. I'm the director of the Division of Nutrition, Physical Activity, and Obesity. Today, I'm going to discuss the environmental determinants of childhood obesity, CDC's approach to the epidemic of childhood obesity, the appropriate behaviors and targets and strategies to address them, and several examples from the field that demonstrate the efficacy of interventions and progress being made. The shifts in BMI in adolescence that Cynthia described can be accounted for by an excess of 110 to 165 calories a day between 1988 and 2002. This modest imbalance likely results from multiple small changes in energy intake and energy expenditure. This photograph shows what an average American family of 4 consumed in 1952. Notice the almost complete absence of processed food. Contrast 1952 with today's family, shown here with the food that they consumed in the course of a week. Note the relative paucity of fruits and vegetables and the number of high-calorie foods. These shifts reflect multiple changes in the food supply, such as the increased costs of fruits and vegetables, the decreased costs of foods high in fat and sugar, as well as an increased variety of foods. These factors combine to increase the intake of less healthful foods and reduce the intake of healthier options. Although the changes in physical activity are harder to document, this graph shows that physical activity as part of daily life for children has changed substantially over the last 40 years. Walking and biking to school has decreased, while car transport has increased. These shifts reflect changes in community design as well as concern about child safety. Television time is also associated with obesity. Food is heavily marketed to children on television, and the more television that children watch, the more likely they are to eat while watching television, and the foods they consume are those advertised on television. Television in children's rooms increases television time and also increases the risk of childhood obesity. To reduce childhood obesity, we believe that the identification of cause is less important than the identification of effective interventions. There are many examples in medicine of effective therapies for disease where the cause has not been identified. For maximal population impact, we should focus on population strategies that alter the food and physical environment in places where people live, learn, work, play, and pray. Interventions aimed at single targets are unlikely to have a significant impact. Like tobacco, multi-sectoral comprehensive approaches should be the goal, and we need to rely on both traditional evidence as well as practice-based evidence. I would like now to turn to new opportunities for obesity prevention and control. These include Let's Move, the First Lady's initiative that aims to end childhood obesity in a generation. Let's Move also included establishment of an intergovernmental childhood obesity task force, which added child care and pregnancy to the pillars of Let's Move. An HHS Healthy Weight Task Force is developing broad approaches to obesity in multiple sectors, and you will hear shortly from Judith Bell about the work of the Convergence Partnership. 2 other programs initiated by CDC with funds from the American Recovery and Reinvestment Act provide key learning laboratories for nutrition and physical activity strategies. These programs include Communities Putting Prevention to Work, which provides $373 million for 44 communities. 30 of these communities are focused on nutrition and physical activity. In addition to the 25 states we already fund to address nutrition and physical activity, a state and territorial initiative of Communities Putting Prevention to Work provides $120 million for all states and additional funds for 8 states to focus on nutrition and physical activity. These programs provide opportunities to examine the impact of intensive interventions at the state and community level. Our state and community programs are expected to address many of the behaviors shown here through policy and environmental changes. I will focus on interventions that promote breastfeeding, reduce energy intake, and increase energy expenditure. Breastfeeding has substantial health benefits for children and reduces the risk of early childhood obesity. However, our most recent data indicate that almost 30% of mothers choose not to breastfeed, and only about 40% of infants are still breastfed at 6 months of age. A study of mothers' experiences during their maternity care hospital stay found that the number of baby-friendly steps the mother experienced in the hospital effectively predicted her breastfeeding duration. These included early initiation of breastfeeding, exclusive breastfeeding, rooming in, and several other strategies. Nonetheless, few maternity hospitals currently support these practices. Soda and juice are the biggest contributors to excess energy intake in youth, and substitution of water for sugar-sweetened beverages can reduce caloric intake by 235 calories per day in 2 to 19-year-old children. Efforts by states, communities, and the Alliance for a Healthier Generation have reduced the amount of sugar-sweetened beverages consumed in schools. However, the reduction in sugar-sweetened beverages is only a fraction of the total calories derived from sugar-sweetened beverages. Strategies to further decrease the intake of sugar-sweetened beverages include regulations that eliminate the use of sugar-sweetened beverages in childcare and after-school programs, the increased availability of fresh, good-tasting water in parks and recreational facilities, and increased prices for sugar-sweetened beverages and lower prices for healthier options in vending machines. Half of all the money spent on food outside the home is spent on fast food. Menu labeling has been mandated as part of health reform and has an impact on choice and in some cases has led to product reformulation. Several years ago, Disney changed the default choice for children's meals in its theme parks to fruit and milk with no apparent change in revenue. Several weeks ago, 16 companies that are members of the Healthy Weight Commitment and provide 25% of the U.S. food supply announced that they would change their products to reduce calories by approximately 12.5 calories per capita by 2015. Finally, purchasing strategies by institutions such as childcare can reduce the availability of high-calorie foods. The relationship of television time to childhood obesity appears mediated by the $800 million that companies spend annually to promote high-calorie foods to children. Strategies to reduce the impact of advertising include limiting exposure by reducing television time. This strategy includes regulations that limit TV time in childcare settings and keeping televisions out of children's bedrooms. Companies that account for over 2/3 of children's food and drink ads on television have agreed to limit foods advertised to children in an agreement known as the Children's Food and Beverage Advertising Initiative. However, one study has shown only modest shifts in the products advertised. A working group consisting of 4 federal agencies has recently proposed more rigorous standards for foods advertised to children, but these have not yet been formally released for comment in the Federal Register. Physical activity is one of the pillars of Let's Move and the Childhood Obesity Task Force because physical activity plays an important role in the prevention of obesity and can reduce the hyperlipidemia, hyperinsulinemia, and elevated blood pressure associated with obesity, even if weight is maintained. Providing children with safe routes for walking or biking to school offers an important opportunity to restore daily physical activity and to reduce car traffic around schools. Likewise, restoration of physical education programs in schools provides a safe environment in which children can be physically active. Recent analyses by CDC's Division of Adolescent and School Health indicate that school-based physical activity has a positive impact on academic performance. An example of a school-based approach in Philadelphia emphasizes the impact on 4th to 6th graders of a comprehensive program that focused on reduced television time, increased physical activity, and increased fruit and vegetable intake. The intervention was based on CDC's school health guidelines for nutrition and included changes in the school food supply to meet the dietary guidelines for Americans. The 2-year intervention resulted in a 50% reduction in the incidence of overweight and a 10% reduction in the prevalence of overweight. Both inactivity and television viewing also declined. In summary, policy and environmental interventions show early evidence of efficacy. Nonetheless, we need more studies of impact and effectiveness, and we need to identify and evaluate promising approaches from the many natural experiments that are going on around the country. Although decreased consumption of sodas and juices in schools and the reductions in calories in the food supply announced by the Healthy Weight Commitment are steps in the right direction, they only account for a fraction of the calorie gap associated with obesity. Additional efforts are needed to reduce this gap even further. And finally, the combination and dose of strategies to control childhood obesity is still uncertain. However, the high visibility accorded to childhood obesity by the Let's Move initiative and the states and communities funded by Communities Putting Prevention to Work provide us with an unparalleled opportunity to reverse the obesity epidemic. Thank you. It's now my pleasure to introduce Judith Bell of Policylink.
Good morning. I'm Judith Bell, and I'm the president of Policylink and also the program director for the Healthy Eating, Active Living National Convergence Partnership. I will start with a brief introduction of Policylink and the Convergence Partnership, and then discuss the partnership's efforts focused on access to healthy food, building the field locally and regionally, and the built environment. Policylink is a national research and action institute advancing economic and social equity by lifting up what works. We partner with equity advocates at the local, state, and national levels to highlight best practices and create policies that build a just and fair society. Broad national partnerships are instrumental to achieving equity. The Convergence Partnership is a collaborative of 6 national foundations and healthcare organizations, with the CDC acting as a technical advisor. The partnership seeks to support and foster multi-field, equity-focused policy and environmental change efforts to achieve healthy people in healthy places. Policylink is the program director for the partnership, providing guidance and policy about strategies to advance the partnership's mission. Changing policy is often the most effective way to implement and sustain the kinds of environmental changes that Dr. Dietz just described. Policy changes can have broad impacts, and policies not traditionally thought of as health policies, transportation, land use, education, agriculture, can affect health and obesity rates. The Convergence Partnership has focused its funding and advocacy on access to healthy foods, building the field locally and regionally, and the built environment. So let's dive into the issue of access to healthy foods. The last Farm Bill introduced the issue of food deserts to national policymakers. The USDA conducted research and concluded that there are more than 23.5 million Americans that live in food deserts, areas without access to healthy foods. Low-income communities of color are particularly affected. The USDA data and other studies clearly show that this is a national problem with serious implications for equity, health, and obesity. This is a problem not just in urban areas, but in rural areas as well. On this map, the darker areas are ones where 60% or more of residents must drive 10 miles or more to reach a supermarket or supercenter. The lack of access to healthy food affects health. In rural Mississippi, adults living in counties without supermarkets were 23% less likely to meet guidelines for daily fruit and vegetable consumption compared to adults living in counties with supermarkets. Lack of access to healthy food in urban areas is illustrated here for New York City. The darker the color, the greater the need. The areas with the highest need are very similar to those with the highest concentrations of residents who are overweight and obese, and those with residents who report not eating fruits or vegetables in the last day. Several studies, including this one for California, find that people in lower income communities of color are more likely to live in worse food environments. This study found that obesity and diabetes prevalence is highest for those living in the worst food environments, a 20% higher prevalence of obesity. Even looking only among low-income communities, those communities with the worst food environments have higher rates of obesity and diabetes. Improved access to healthy food is tied to changes in eating habits, and changes in eating habits are tied to decreases in overweight and obesity. The Fresh Food Financing Initiative in Pennsylvania is an innovative public-private partnership that has dramatically improved access to healthy food using one-time loans and grants. Since 2004, the Fresh Food Financing Initiative has supported 83 projects across the state, from full-scale supermarkets to small groceries to farmers markets and co-ops. The state's original $30 million investment has been leveraged with private capital to become more than $190 million in total project costs. As a result, more than 400,000 people now have access to healthy food who did not have it before. 5,000 jobs have either been created or retained, and more than 1.7 million square feet of retail space has also been created or saved. This is a triple bottom line impact: health impacts, economic impacts, and neighborhood revitalization. Replication of the Pennsylvania policy is underway in many states. The Convergence Partnership is supporting efforts to bring it to scale at the national level. And there are other innovations underway in communities to improve access to healthy food, particularly for low-income communities of color. The President's proposed 2011 budget includes support for a healthy food financing initiative based on the Pennsylvania model. The President proposes spending $345 million for loans, grants, and tax credits to support a range of projects designed to increase access to healthy food. The Convergence Partnership is supporting efforts to make this proposal a reality. A broad coalition has come together in support of the Healthy Food Financing Initiative, including the grocery industry, unions, health, civil rights, and children's organizations. The First Lady has been a big champion, and the Healthy Food Financing Initiative is included as a pillar of her Let's Move initiative. Now let's shift to look at some of the partnership's efforts to build the field locally and regionally. To build the field, to increase equity-focused activity on land use, built environment, and access to healthy food, the Convergence Partnership launched an Innovations Fund, an effort that provides 50% matching dollars to foundations to support multi-field collaboratives working on these issues. So far, with more than $4 million committed, a variety of 15 projects in different places with different types of grant making and partnerships have been launched. In order to increase the number of foundations engaged in these types of efforts, the Convergence Partnership has been supporting efforts that are similar to the national convergence effort in many regions across the country. Dr. Rodgers, the next speaker, is a leader in the Maine convergence effort. These regional convergence efforts are focused on policy and environmental changes to improve healthy eating and active living and reduce obesity. The work of the Convergence Partnership has also included educating the field around built environment strategies for walkable and bikeable neighborhoods, places for physical activity, and to ensure that there are analyses and adjustments made for health impacts. The Convergence Partnership commissioned a series of papers collected in the volume The Transportation Prescription that focus on transportation and equity and the impacts of transportation on the built environment and on health. In addition to its education efforts, the partnership has also been supporting advocacy on transportation. Every 5 to 6 years, the federal transportation legislation is reauthorized. This is a massive investment of federal funds that flows through states, regions, and localities to fund highways, public transit, pedestrian and bicycle facilities, safe routes to schools, and complete streets. The last reauthorization was for $244 billion, with 80% of the funds going for highways. These funds have clear impacts on the built environment and on equity and on health. In fact, research shows that the more vehicle miles driven, the greater the risk of obesity, and those who use public transit are less likely to be obese. The Convergence Partnership is supporting efforts to change the next reauthorization to improve its health impacts. Already, the public education and advocacy efforts have increased awareness of the connection between health and transportation and have also altered policy proposals. In addition to supporting education and advocacy efforts, the partnership has been adding its voice for change, including for health reform, sustainable communities, and obesity reduction. Clearly, momentum is building. There are many multi-sector, equity-focused efforts advancing at the local, state, and national levels. As we move forward, it is important to continue to find and support local innovations focused on equity impacts and the efforts to bring them to a national scale. Our next speaker will talk about a local effort that is taking off nationally. Thank you very much.
Hello, my name is Torie Rodgers. I'm a pediatrician from the Barbara Children's Hospital at Maine Medical Center in Portland, Maine. And I thank you very much for the opportunity to talk to you about our Maine story and our story of community action. I've been working in the field of childhood obesity for about a decade. First as a practicing pediatrician on the front lines, dealing with this every day, and then I worked with a number of national programs throughout the country, and then on to advocacy in my own children's world of school nutrition and sports snack shacks, and now as the medical director of Let's Go, a multi-sector approach to addressing childhood obesity. Now I'd like to tell you about the story. So the Maine story starts like many stories of community action occurring across the country. However, I think ours has a bit of a twist. The twist being that the medical community got involved very early on by engaging community partners, the Maine Harvard Prevention Research Center, and the Maine CDC, our public health entity in Maine. And what we did is we developed simple steps that clinicians can do every day to start to combat the obesity epidemic. This led to the formation of the Maine Youth Overweight Collaborative. And then in 2006, this work expanded into other sectors through the Let's Go program, which initially started in Greater Portland. And now in 2010, Let's Go has been disseminated to 7 additional sites and regions in Maine, and we're actively participating with the Convergence Partnership, as Judith mentioned, and the local communities putting prevention to work recipients. Now I'd like to say a few words about MIAC, about Let's Go, about our evaluation, and about some of the challenges that we've experienced and the opportunities that still lay in front of us. So MIAC started with a very simple message, 5210. It stands for 5 or more fruits and vegetables on every day, 2 hours or less of screen time, 1 hour or more of physical activity, and 0 sugary drinks, drinking more water and low-fat milk. This message was really central to the engagement of the primary care providers. And I think, as you will see as my presentation goes on, 5210 has become a very persuasive message, which is beginning to change the landscape for kids in Maine. Our work as part of, in MIAC, we had a clear ask of the physicians because they get overwhelmed. What are we going to do? What are we going to do? So we had 5 specific things we asked them to do. Create awareness, hang a poster, 5210 Let's Go poster, assess the patient's weight accurately, listen to patients in a respectful manner using the 5210 approach, to be a role model, that was critical, and also to join the learning community, to continue to learn and innovate. Here's the provider toolkit, which shows many resources that have been used, adopted, and adapted throughout the country. So what did we actually do in MIAC? Well, we did some pretty impressive things, I must say. We engaged 12 physician practices, changing clinical practice, and making office system changes. And here's some of the data from MIAC. We looked at physician behavior by measuring a number of process outcomes at the beginning of MIAC and then again at the end of the 24 months. Here you can see a large increase in the percentage of physicians using a questionnaire on physical activity and nutrition, the 5210 questionnaire. Okay, now full disclosure here. Some of you may realize that there's nothing on the pre-MIAC, right? That really was zero. We developed the 5-2-0 questionnaires going on because the clinicians had nothing to use in their offices that they thought was simple. This tool was really central to the engagement of the clinicians, and it was the single most effective tool the clinicians had because it changed the conversation from weight to behaviors. Before MIAC, only about 25% of the time clinicians were documenting BMI percentile for age and gender, even though they knew they had to do it. And after MIAC, about 90% of the encounters had a BMI percentile documented. Over the course of MIAC, the clinicians' knowledge of the CDC definitions of weight categories increased. Here you can see additionally there was an increase in the provider behavior in these key areas of addressing and medically evaluating overweight, using brief focus negotiation and goal setting with patients and families, and scheduling follow-up visits. So the lessons learned from MIAC were that 5-2-0 was a simple message. It was easily deliverable by clinicians and easily understood by patients and families. And starting tomorrow, there were some very simple things that the clinicians could do. So then in 2006, a group of local businesses and healthcare leaders in the greater Portland area, identified on this slide, came together and made a substantial investment in the prevention of childhood obesity. They formed a unique nonprofit partnership called Let's Go. Let's Go uses the lessons learned and the tools and resources that were developed in MIAC to take the 5-2-0 message to additional sectors. Let's Go works in 6 key settings: childcare, school, communities, workplace, after school, and healthcare. Surrounding this work is a robust media campaign focusing on 5-2-0. The core principles of Let's Go are here. They are environmental and policy change, which are key to influencing the behavior change. The interconnectivity across sectors is crucial. Strategies are evidence-based and continually to be evaluated. Now I'd like to take a few minutes and talk just about a couple of the sectors. This first one, the school component of Let's Go, is called 5-2-0 Goes to School. The program takes schools from where they are around health and physical activity and nutrition to where they want to go. We use 10 key strategies which focus on sustainable environmental and policy change. These 10 strategies are listed here, and you can see that there's a broad range from encouraging healthy choices for snacks and celebrations to including community organizations and wellness programs and incorporating physical activity into the school day. Now I'd like to talk about our work in early childhood. In the early childhood sector, we are working on bringing 5-2-0 into the home, into the child care centers, and into home-based child care sites. We are also working on the development and implementation of statewide licensing, regulations, standards, and rewards. In our community work, it's included trail development and some innovative work combining health and literacy by implementing something called story walks. A story walk takes a book and makes the pages come alive along a path outside of a school, a library, or a community trail. It's truly one of my favorite things that we do. We have a robust evaluation plan which really focuses on quantitative and qualitative data along with hundreds of stories, and the stories are so compelling. Currently, we are tracking local obesity prevalence rates, behavior changes, and environmental and policy changes. As many of you know, it takes years to see drops in obesity rates. Therefore, we feel it is critical to track our progress with environmental and policy changes, as well as behavior data as precursors to changes in the weight status in a population. The following is our most up-to-date evaluation. As I said, it's very important to have local data, but to have local data, you've got to go out and get it. It doesn't just get given to you. Using data gathered from pediatricians' offices in the greater Portland area in 2006, we have determined a baseline overweight and obesity prevalence rate. The local data is here in light blue, and the 2006 NHANES data is in dark blue. Our local data mirrors the national data with the exception of the youngest children, which are significantly heavier than their national peers. We are on track to report 2009 data in late fall, and then we will be monitoring this on a periodic basis. We have also been tracking knowledge, attitude, and perceived behavior changes through a random digit dial telephone survey to parents of school-aged children in the greater Portland area. There is an increase in the awareness of Let's Go and 5-2-0 from 2007 to 2009. Although this slide doesn't depict it, we also see a very favorable response to the message. If a parent is exposed to the 5-2-0 message in 3 or more settings, they are more likely to be aware of 5-2-0, to be more favorable to the message. They are also more likely to be able to identify all 4 of the healthy behaviors. Of note here is that from 2007 to 2009, there was an impressive increase of 27% in perceived behavior change in 3 out of the 4 5-2-1-0 behaviors. In schools, we are beginning to see the environmental and policy changes. A majority of administrators reported an increase in physical activity and healthy eating options. In the greater Portland area, over 90% of our schools have reported making at least 2 or more environmental and policy changes during the 2008 to 2009 school year. To date, 5-2-1-0 Goes to School has made progress implementing the key 5-2-1-0 strategies. The schools are very much appreciative of the simplicity of the message, the support from Let's Go, and the multi-sector approach. The senior administrators have really played a key role in our success, and policy and environmental change is critical to the long-term support of behavior change. Let's Go has started to expand statewide, and by June of 2010, we are reaching over 80,000 students in 262 schools, 40 child care sites caring for thousands of children, more than 50 physician offices, numerous after-school programs supporting more than 2,500 youth members, 6 of Portland's largest employers are involved, and 8 regions across the state we are actively participating with. This is a map showing where 5-2-1-0 is. We're in 149 towns. We actually are in more towns, but they overlap the dots, so I have to just say that. This is also where we are across the country. We've been able to use our tools, and we've provided some technical assistance to many of these sites. Now I'd like to take a minute and talk about the challenges and opportunities ahead of us. Our first challenge was to build the evidence. We had been encouraged by many of you in this audience, Dr. Bill Dietz, I might say, to innovate, to try new things, to build the evidence. Go ahead, Torie, do it. However, I have to tell you, many funders aren't that interested in funding innovation. The second challenge was to really manage the expectations of the funders and partners who expected to see fast changes. They wanted the obesity rates to drop rapidly. Additionally, when evaluating behavior change, as many of you know, it can be very difficult to get accurate data in children. This is one of the reasons we look to our environmental and policy data as our first line of the evaluation plan. Our next challenge is related to conducting research in the community. It can be very difficult to get community data. Many community partners are wary of research. They think it's going to take too much time. They wonder how the data is going to be used. Will it affect any state or federal funding? Collaboration among partners is essential, but there are always turf issues. We all know this. And partners may have different agendas. They may have different funding streams, and this can be an additional complication. So although the challenges may have seemed daunting, they really haven't prevailed. There's a growing number of opportunities that has allowed us to succeed and continue to be optimistic. As we wait for the big changes that were mentioned earlier in this presentation, which I think are critical, it really is the small changes that keep the progress going. It's changing rewards from children, from food to physical activity, changing the healthy options in the sports snack shacks, changing school fundraisers, changing what happens in the child care setting as examples. Engaging all sectors really has allowed a number of interesting partners to come to the table because they didn't feel they had to own it all. The docs could do their piece, the schools could do theirs. And working in a small rural state has its challenges, but really has the opportunity that we have access to local and state leaders, and this is critical to our work. The collaboration with the Communities Putting Prevention to Work recipients and the Convergence Partnership has brought regional and national attention to our work, and this has been very, very helpful in keeping our work up to date and has re-energized the staff. Lastly, I want to leave you with one last slide and one last story. You know, Maine is known for a number of things, but to me it's really known for its common sense approach to handling many difficult problems, hardworking people, innovation, and a little quirky sense of humor. So in the early days of this work, before Let's Go started, we were just working in the doc's offices, we didn't have a media campaign, and we were trying to get the 5-2-1-0 message out. So one of my local colleagues who travels around the state doing outreach clinics says, Torie, I've got an idea. And this was his idea, and this is his car as he travels around the state. So thank you very much.
Thank you. I think we're now open for questions or comments. Please use the microphones that are down in the middle of the auditorium. Terry?
Excellent, and I'm Terry Bocek from Office of Smoking and Health. Given the information about dynamic local action, I would appreciate the panel discussing the pros and cons of accepting preemption of local action to get a national change, such as menu labeling, and which preempted local action. The pros and cons. Yeah.
I can start on that. Can people hear me? Yeah. So I think two things I'd say. One is you never get to national action, or rarely do you get to national impact without first starting with the local innovation. So all of those really important steps on menu labeling in cities and states were what got us to national action. And I think it is one of these balancing acts. And before I think we should accept preemption, we should make sure that the national standard is as strong as we possibly can get there. And I think it's up to advocates and policymakers to push as hard as they can. And then ultimately, I think in many cases we end up having to accept it because it gets that change to places where simply there isn't the capacity of advocates nor the political will to make the change happen.
Hi, Dr. Jewel Crawford. I'm at ATSDR in environmental medicine. And the question and the comment that I have is, here in DeKalb County, where we are right now, there's a real scarcity of places for kids to play. I mean, we don't have a lot of playgrounds or public parks. I mean, they have parks, but people have to drive to them and people have to pay. Like Stone Mountain Park, you have to pay to get in there. And it's not like other cities that I've lived in, New York, Portland, Oregon, where children can walk to playgrounds and parks, and also lack of sidewalks. So, and I mean, that's right here where CDC is. But any suggestions, for how to go about getting more play spaces? Because there really aren't a lot of places for the kids to go outside and safely play, from what I can see.
Yeah, thanks for that question. We're very interested in mapping play deserts in the same way that food deserts have been mapped. It's a little more challenging, and we're not there yet, but that's step one. Step two, in my opinion, the Atlanta Beltline is probably the most important public health intervention in Atlanta since potable water. Because it's going to connect communities, it's going to build parks, it's going to have walking trails, perhaps light rail bike trails. And that's what this city needs. I mean, this city was not planned in a very responsible way. I mean, it was just spread out along Peachtree with the advent of cars, and we've been car dependent ever since. So I think support for the Beltline, and as the Beltline comes in, making sure that it connects people to places so that they can use alternative forms of physical forms of transport, I think is going to be a key outcome, and it's going to be accompanied by places for children to play.
Thank you.
Thomas Morris, so DSLR. Just to make a note, I'm probably one of those rare people that actually grew up in Atlanta, and I had a very close relationship with my bike. In fact, I was a bike racer at one time. I find the streets here appallingly resistant and narrow for trying to bike. I avoid sidewalks because of pedestrians, glass, debris, things like that, and yet there's barely enough room to fit 2 SUVs on some of these roads, especially around here. The other is a question. How is the physical education component of this reconciling with No Child Left Behind and the big emphasis on test scores, which means getting those kids to sit still and actually learn something?
Great question. There's so much data that's come out over the last 5 years about the association between physical activity and academic scores, and that needs to be a critical link. I do a lot of talking to school boards about this. There's also the same link with healthy eating and academic scores. And then I would also say that we often, there's been some creative work that's happened with schools where kids are not sitting still. They're actually sitting on those exercise balls, and they're actively moving. And the teachers are saying their classes is so much more controllable because kids are allowed to do what they need to do when they're first and second graders. I'd make the same case that could be for all children. So I think there's that link, and that we've done that work with the schools that we have, showing that link between physical activity will improve the the scores of No Child Left Behind, or scores of the school scores.
Good morning. Jelani Akil. So playing off the local innovation idea, where do we get funding, or what suggestions do you have for funding to create local grassroots programs, such as, for example, bringing a nutritionist together and a trainer together and bring them into a park or a facility or something, and getting funds to really put together a program for children to where they can play, educate them on eating habits, and you have them for a couple hours and include the parents. And where can we get money to fund a program such as this?
Well, there are numbers of foundations that are engaged in this work. So the Robert Johnson Foundation, for instance, has a $500 million effort to reduce childhood obesity, and they're funding all across the country in many different types of activities. We are hopeful that some of the prevention dollars will be used to foster community efforts around innovation. And then the last thing I'd say is there's advocacy to be done with city budgets to make sure that parks and recreation are adequately funded, and to make sure that there's an understanding and that link between health and physical activity.
I would just add to that start with your local institutions. I mean, if you have children in childcare, that's one place to start. If you have children in schools, that's a second place to start. And that characterized a lot of Torie's early experience with these issues.
The other thing I'll add is, so that's fantastic. Some of those monies are difficult to flow down. And we've done a lot of this work. The community, local community groups that get together, whether it's the local Rotary clubs or the different kinds of clubs that get together, oftentimes are looking for this. And this doesn't have to be a lot of money, to be honest with you. The other thing that we've done is partnering with our local high schools. All the high schools need to do community service, at least in a number of the states. So you can often use local high school students to do some of this work. So there's a lot of things that you can do, and then sometimes by that success, you have that opportunity to go on and apply for a larger grant. So getting started will kind of move you in that direction.
Thank you.
Eduardo Simões with the Prevention Research Centers Program at CDC. My question is actually to all of you, but likely more for Bill. It's pretty evident that the policy and environmental change are very appealing, because when you change a sidewalk, you are helping everybody, kids, adults, all races, all ethnic groups, all socio-economic background. However, given the fact that our colleague from and CHS brought some relevant data on Hispanic kids and African American girls, is there any room for target initiatives for those specific populations, Bill?
I'm going to ask Judith to help to respond to this as well, but I think that those disparities, the gender disparities, bespeak a cultural determinants of obesity. And frankly, I don't think we understand enough about why that disparity exists in the Hispanic community. I mean, I think we have some anecdotal evidence, but from the messaging point of view, I think it's terribly important. How do we talk to Hispanic parents about parenting practices that lead to differential levels of physical activity, or different patterns of parenting around food intake in Hispanic families or African American families? That's one of the areas that I'm not sure responds easily to a policy initiative as much as a messaging or communications issue.
I think we have to target some of these resources, because when you look at communities, what you see is that for people to make the healthy choice in low-income communities, it's far harder than it is if you're in a middle-income or higher-income community. And that's why the data looks the way it does, frankly, I think, is in large part, think about the data I spoke about in terms of rural Mississippi, right? If you're not near a supermarket, you're just not going to eat as healthy. We found that that was true regardless of what income you were. So if you lived in a neighborhood with a high concentration of fast food and convenience stores, you had a higher prevalence of obesity and diabetes. So there's no question the environment matters, and that speaks to targeting changes in the environments that need them the most.
This will be the last question.
Good morning. My name is Michelle Moses Eisenstein, and thank you all so much. I'm wondering, what is the role of mental health for the obesity epidemic? And in relation to one of the slides, it just seemed, aside from even in healthier income levels where they might have more opportunities to have safe places to exercise and afford food, there were still greater amounts of obesity. So I'm just wondering, what is the role for mental health policy?
You can see we're all jumping at this one. I think the relationship with mental health is fascinating, because folks who may be struggling with mental health issues and may be put on medications may put them at more risk for weight issues. So that's one component that clearly needs to be addressed and is very difficult. The other side of it, there's a lot of data that shows that kids' quality of life when they're obese, and the severe obesity greater than 97th percentile, is very poor. It needs to be addressed. We've worked a lot with clinicians on that, and there's other data on that. We could probably talk for a whole hour. I think the role, from my point of view as a clinician and working in the community, is it needs to be, you need to be aware that it's there. You need to be aware that the mental health issues for the severely obese are very much a part of how you're going to work with them.
Well, I'd like to close by thanking the panelists who I've invited, Cynthia, Judith, and Torie. Thanks very much for your participation.
I have one very quick announcement, and that is because we have received so many requests from colleagues outside of CDC and our external viewers to move the time of these sessions to a time when people on the West Coast and other parts of the world can watch them. We are going to do that either in August or September. Our next session in July is going to stay at the same time, because we expect a lot of colleagues from Europe and Africa will be interested in it's on global health and child survival. But starting in August or September, we're likely going to start around noon. Thank you so very much for coming out in this large number in person, and see you in 4 weeks, same time, same place.